Okay, I think we're ready to start.
Wonderful. Let's see. Bobby, do you mind just pulling down the slide so we can see everyone? All right. Well, I want to welcome everyone to another meeting of our Community Vaccine Advisory Committee. I want to thank all of you for being here. As we get started, I want to start by making a brief mention of some of the remarkable events that have been transpiring across the country today. And I want to recognize that for many, it's quite distressing, and encourage folks who, to reach out, to practice that self-care, to reach out to those that we trust, our sources of support. And for anyone who's needing additional support, there are resources at our covid19.ca.gov website, the Surgeon General's playbook for stress relief. We could all use a little bit of stress relief right now. Stress relief during COVID-19, and also some emotional wellness resources. So I just wanted to highlight that as we start this meeting, and also offer my gratitude to all of those who are participating in this process, for really coming to the table with that spirit and grounding in the values of safety, equity, and transparency as we come together to work to end this pandemic and really to protect all Californians as we're working together on this vaccine advisory process. So I just wanted to start with a note on that, and invite my co-chair, Dr. Erica Pan, to offer her words of welcome as well.
Great, thank you, Dr. Brooke-Harris. And I just want to appreciate as well what you just said about how stressful what is going on and how stressful this whole year has been. And again, thanking all of you for your time spent today with us and contributing to our efforts and our statewide efforts together. I thought I would start today as well, just giving a few highlights. The governor just had a press conference, and a lot of the highlights were about vaccines. So I wanted to just sort of share much of that as well. And I know this may answer some of the questions that have come up as well. I think we are, clearly recognizing that we need to accelerate our administration of vaccines in California and nationwide. And so we have really stepped up in the last several days, kind of our commitment to finding other resources to help support what's happening on the ground and at the local level from the state. So we are working, to continue with our equitable, safe, and transparent work, as again has been working with you. But as far as operationalizing all of this, we've thought a lot about flexibilities within the priority system. We've gotten a lot of feedback over the last, couple weeks after the vaccine had arrived that, we continue to want to balance the priorities and making sure we get to the highest risk people soonest when we do have this scarce resource. But I think as the reality has hit, and especially as the vaccine gets dispersed across a large state like this, in certain smaller jurisdictions, you can get through those higher priority groups much more quickly than others. It just depends on the makeup of the local community. So we really want to make sure people are understanding that you can be flexible with our priorities. You can move through those groups after you've done a good job offering to all the people and making sure that vaccine is accessible to those in those highest groups. So we're creating more flexibility and making sure we have communications about that to move through the priority tiers. And we have vaccinated a lot of people in a higher proportion, but we do need to move faster, especially in the middle of this surge. And these are, as we've talked about many times on these committee calls as well, this is our light at the end of the tunnel. So we're really doubling down also on our partnership with other healthcare leaders, again, to really expedite getting vaccine into people. So a few of the things that we are working on are including, expanding our flexibility around this. As I just mentioned, we're working really hard in creating a larger pool of vaccine administrators. Again, heard a lot of very concrete feedback from at the local level and healthcare systems, in the middle of this surge, we're already, as you've been hearing from other communications from us, our healthcare system is really stretched right now. So those would be people we had been relying on to do a lot of vaccinations are busy taking care of, ill patients in the hospital. So creating a larger pool of vaccine administrators, adding more state support to help do kind of on the ground clinics, making sure we're vaccinating the vaccinators. You may have heard earlier this week about, making sure dentists are trained to vaccinate and get out there and vaccinate. And we are working with partners to reach 1 million vaccinations in 10 days. So that's kind of our latest goals. So we have almost 2 million doses have been shipped to California. We still, I think a lot of people are asking a lot about data. We know it's shipped, and then the data systems are a little bit more challenging on exactly when it's been received at all these different providers across the state. But that's the number that have been shipped. And then we know we have administered, as of yesterday, almost 490,000 doses of vaccine. And I think, that is a constantly changing number as well. There may or may not be there. We think there might be some data lag in reporting that, but so almost, getting close to 500,000 doses administered. And again, our goal is to administer another 1 million in the next 10 days. And then just to reiterate, as well, we'll be talking more about the phases, I think, later on. So again, just wanted to talk through that 1A is all healthcare workers, and then residents of long-term care facilities like skilled nursing facilities, residential care for the elderly, et cetera. So, and then I think, I know there'd been some questions about funding that's coming this way. Oh, actually, I also wanted to mention too, we're really emphasizing we want to use every single dose. So again, trying to balance the unique challenges of especially these first 2 vaccines that have been out, as many of you have heard, are that they have unique storage as far as ultra cold freezing. And then once you bring them out, you have to use them a certain amount of time or hours. So we really want to make sure that frontline providers realize once you've covered as many people as possible in your community that are in that current tier, to move to the next group and continue to offer a vaccine to all the higher priority groups. But once you've done that, and if any demand subsides, and if your doses are going to expire, again, the priority is to get vaccine into people and not waste vaccine. So, and then funding wise, I know there are a lot of questions. There is to the tune of about $300 million that's we are receiving for vaccines, and people are wondering what that's going into. So there's 3 big buckets as far as that goes. A lot of information technology has been really crucial, and something we need to really also make sure, everything from these mass vaccination clinics and getting providers enrolled, getting people and their appointments to have their vaccines are all important technology, being able to report back to the CDC. So CalVax is our main system to do a lot of that, and investing in that, making sure it's successful. And then there's a lot of logistics and commodities funding that continues to be needed. So everything from containers, dry ice, freezers, all of those things take funding as well. And then certainly public education campaigns. So engaging our public through culturally competent campaigns and making sure we do the right research to inform that is all an important part of the funding and where that's going. So those are some big highlights I wanted to share from the state. And then it is my huge pleasure to introduce our new Director and State Health Officer, Dr. Tomas Aragon, who joins us from San Francisco. And I've had the pleasure of working with a lot over my public health career as well, and really thrilled to be working with him again more closely. So with no further ado, I will introduce Dr. Aragon.
Thank you, Erica, and thank you, Nadine, and I've had connections to both of them in San Francisco. Both of them have inspired me, so I feel incredibly grateful to be able to work with all of you. So my name is Tomas Aragon. So I've been in public health for over 20 years, and my core training is in infectious diseases. And I never imagined that we would ever be where we are today, even though I spent many years planning for this. And so we are really making history, and you're making history. And so, and I think right now, today it really is a transition phase for all of us, both nationally and here locally, with the change of administration, the emphasis on vaccinating people as much as possible, with a real focus on equity. I want to mention a couple of things. a little bit about the way my leadership style, which I think really aligns with the way you're running this committee, and that is really emphasizing what I call universal values, which is dignity, equity, and compassion for everyone, every single person, including people who we may have disagreements with. That if we treat everybody with dignity, equity, and compassion, we're going to find the common ground and solve problems. We really have to reach out and make sure that we connect with everybody. And then from the equity component, I do want to just emphasize is that we do have incredible equity challenges across the state and the country, especially with the Latino and the Black African American community. So I really want to express my gratitude that I know that that's being addressed. It's so incredibly important. And I think there's a lot more to do in that area. And so we have a long path. And so this is really an opportunity to hopefully shed light, not just on the problems, but also how it's been amplified with the COVID pandemic. The last thing I want to mention is that I'm on the Vaccine Safety Review Committee, and recently the committee met on Monday to discuss a couple of issues that have been that you may have read in the newspaper about the possibility of extending doses by actually three potential strategies. One is using a half dose. The other potential strategy is delaying the second dose. And the third one is mixing and matching the different mRNA, which is the Pfizer or the Moderna. These are strategies that you may see, you may read about, and you may see other countries. I know, for example, in the UK, they may be doing some of these. Right now, the Vaccine Safety Committee, and this is also true with the FDA, is that currently we will be sticking with the current recommendations. There is not enough scientific evidence at this moment to adopt a new approach. Although I think what you will see is that people will be studying this to gather more information to see if this is a strategy that might be implementable in the future. I did want to mention that the committee is working on writing this up to really explain the rationale. So I want to make sure that everybody was up to date on that. So I don't have anything else to say except for thank you. This is my third day. I'm learning so much, and I know I'm going to be learning a lot more. So I look forward to working with all of you and us making impact in the area of equity. So thank you.
Thank you so much, Dr. Aragon and Dr. Pan. And now I will pass it on to Bobby Wunsch to walk us through again the meeting guidelines.
Great. Thank you, everyone. And welcome and Happy New Year to everyone. What a way to start the new year. I just wanted to quickly review our meeting protocol. Everyone, I think, is well familiarized with this by now. We'd love for the members of the Community Vaccine Advisory Committee to keep their cameras on so we can pretend that we're all together in one room and see each other, and keep your speakers on mute until you're ready to speak. I think everyone pretty much has learned how to use the hand raise icon when you're ready to speak. It's in the participant icon down at the bottom of your screen. And I want to welcome our two ASL interpreters, Katie Sales and Vicki Kennedy, who will be assisting us today. We also have closed captioning, as you can all see at the bottom of the screen, for those who prefer to use that. The public, as everyone knows, is in listen-only mode via telephone, both in English and Spanish, and we are all being live streamed through our own YouTube channel. At our last meeting on December 23rd, we had over 1,900 people watching the meeting. Public comments are welcome. Email to the email address COVID-19 vaccine outreach at cdph.ca.gov. And as we'll discuss in a few minutes, all of those public comments in their entirety are sent out in advance to members of the Community Vaccine Advisory Committee for their review, and I'll be summarizing them in a few minutes. If any of the members have any technical difficulties with Zoom, if you can put your question in chat, our wonderful IT support, Aaron Matlin, will see if he can help you during the meeting with any issues that you've got. So with that, Nadine, I'll turn it back to you. Thank you.
Thank you so much, Bobby. actually, I think right now, sorry, Bobby, did you want to go ahead and summarize the public comments?
Yeah, why don't we go on to the public comment slide? And I know all of you have spent the last few days reading the summary of public comments that I sent out yesterday morning. Those public comments were submitted between December 22nd and January 4th. As I think everyone knows now, we closed the public comment at about 5 o'clock 2 nights before the meeting so that we can compile all of the public comment and send it out the next morning, a day before the meeting, to the members of the Community Vaccine Advisory Committee so that you can review them. I will do a quick summary for those of you that haven't had a chance to read all 387 pages of public comments from 1,034 individuals and organizations. The comments that were received have not been summarized. They were sent out to the committee members and they are now posted on the CVPH website, again, in their entirety. So here is a summary of the comments we received. 4 individuals asked to become members of this advisory committee, including someone representing senior services, 2 people representing people with disabilities, and a hairstylist representing people who provide personal services. We had 4 individuals and organizations offering to provide vaccines or offer their locations, including music venues, as a location for vaccine sites where vaccines could be administered. AARP wrote about an educational campaign that they are about to embark upon. We had 3 public comments about the health and safety of the vaccines. We had 2 comments describing the slow distribution process. We had 5 comments describing what 5 individuals thought was poor messaging by the state of California about how to get vaccines and where to get them. We had 1 comment about expanding the scope of practice of healthcare professionals, including dentists, so that they could give vaccines in their offices. We had 231 individual comments from individuals questioning where they could individually go to get their vaccine, how they could sign up for their vaccine, and where they could be put on a waiting list so that they could be called when it was time for them to receive their vaccine. We had 2 individuals write in to ask what kind of identification do individuals need to bring to prove their eligibility when it's their turn to receive their vaccine. Many questions are still coming in about phase 1A. Phase 1A being healthcare workers, which we're in the middle of right now. We had 88 questions from healthcare workers who can't figure out how to get vaccines for themselves or their staffs and which part of phase 1A they belong in. And that includes people who are not part of health systems, so they don't know where to or who to contact about the vaccine. Includes private doctors who are not affiliated with hospitals, oncology centers, physical therapists, audiologists, midwives, anesthesiologists, nurses, school nurses, nursing students, psychologists, optometrists and ophthalmologists, behavioral health providers, assistive technology providers, surgeons, nurses at border patrol stations, dentists, medical interpreters, hospice workers, jail medical providers, pharmacy staff, dialysis centers, alcohol and drug treatment centers, acupuncturists, all wanting to know where they fit in phase 1A. We had 7 comments from organizations or workers in long-term care facilities and assisted living facilities who can't figure out how to get themselves or their patients vaccinated. A number of requests for how non-licensed senior living facilities and HUD facilities could receive the vaccine. 43 comments from IHSS workers, home health agencies, non-IHSS private caregivers for the elderly and the disabled, and other informal caregivers wanting to know where they could get their vaccines. and who was going to call them. We had a number of questions from seniors and people with disabilities about being prioritized first for the vaccines. 69 individuals urging us to prioritize people over 75 first. 85 comments asking us to prioritize people over 65 first, with another 11 individuals commenting on the age ranges between 55 and 72 as high priority. We had 12 comments asking us to prioritize adults with disabilities first, including people in the home and community-based services waiver programs. We had another 10 individuals urging us to prioritize first adults with intellectual and developmental disabilities. As the allocation process continues, we had a number of comments about the allocation process. Why can't we keep it simple? It seems too complicated to 3 individuals who wrote in. 11 people commented that we should follow the process being used in the United Kingdom, where allocation and prioritization is done simply by age. We had physicians writing in asking if they could have discretion as to who gets the vaccine rather than following the guidelines. We had one comment of someone who says no one should get a vaccine who doesn't wear a mask. The mayor of Oakland wrote in asking that we prioritize people of color. We had 41 comments requesting that people with underlying medical conditions that put them at high risk, including immunocompromised individuals, people living with HIV/AIDS, people with cancer, people with weight issues, people with type 1 and type 2 diabetes, that they be prioritized to receive the vaccine first. We had one person comment that we should only allocate by job categories and not by age. We had 7 comments who said that essential workers who are 60 and older should receive the vaccine first. 3 people who suggested that people who cannot work at home should be prioritized first. 48 comments urging us to vaccinate teachers and school personnel so that the schools can reopen. 4 who suggested that only teachers and school personnel who were going back into the classroom get vaccinated. 1 comment asking that spouses of teachers be vaccinated. 8 individuals and a petition of almost 2,000 childcare providers asking that childcare personnel be vaccinated. We had letters from the mayors of Tulare County, the city of Tulare, the city of Watsonville, the city of Gonzales, and the city of King City, urging that farm workers and others in the agricultural and dairy industries be prioritized first. And then we had another 361 comments from many different groups wanting to be classified as essential workers in phase 1B, including workers and detainees in immigration detention centers, both public and private, workers who work with the homeless, asking that the clergy be part of phase 1B, healthcare administrative services, horse food and agriculture. California Chamber of Commerce wrote in asking that the food supply chain, all workers in the food supply chain be prioritized. Food banks, retail clerks, public transportation, airline crews, utility and water districts, veterinarians, 154 veterinarians wrote in asking to be classified as healthcare workers in phase 1A. The funeral industry, media and journalists, commercial fishermen, waterfront and port workers, security workers, massage therapists, the trucking industry and the Teamsters, the recycling industry, CPAs, the semiconductor industry, small businesses, hotel workers, postal services workers, workers at Amazon, construction workers, public defenders, federal and state court workers, court-appointed lawyers, canine search and rescue workers, workers providing business and residential services like the phone company and the internet service providers. 2 single mothers wrote in asking if they could be vaccinated immediately. One person suggested that college students and their teachers be vaccinated. 2 landlords wrote in asking that they could be vaccinated. We had 13 comments from people urging us not to vaccinate people who were homeless or incarcerated. We had 1 comment from someone who suggested we forget the vaccine altogether and just work towards herd immunity. And we had 23 comments from medical device manufacturers, laboratory organizations, pharmaceutical manufacturers, and nutritional product manufacturers who want to know when do they get their vaccine. And 3 comments from clinical researchers wanting to be categorized as healthcare workers and in tier 1, phase 1A for their vaccines. So I would really urge everyone to read the public comment. The letters and comments are very passionate and heartfelt and serious. And there are still many, many questions amongst the public about how the process is going to unfold. Thank you.
Thank you so much, Bobby, and thank you for all of your thoughtful work around that. So next, we will hear from Dr. Oliver Brooks, co-chair of the Drafting Guidelines Work Group, as well as Dr. Rob Schechter, who is also co-chair of the Drafting Guidelines Work Group. And before we jump into that conversation, I want to remind folks that the purpose of the Drafting Guidelines Work Group is really to take the conversation that we generate here to take into consideration both the science, the data, the public health information, as well as the issues that are raised by you all, by our diverse communities from across California, and put that together into our guidelines that we then share for approval with the governor. And the purpose of that is because we recognize that while we are getting more doses every week and moving this process forward, that we don't expect it to have enough vaccine to vaccinate everyone all at once. And so we need to prioritize, which is really the purpose of the Drafting Guidelines Work Group. And so with that, I want to go ahead and introduce Dr. Brooks and Dr. Schechter, as well as Dr. Ron Chapman from the Department of Public Health.
All right, well, thank you, Surgeon General Burke-Harris, and appreciate your comments, and I will reflect them again. I also want to say thank you to the co-chair of the Community Vaccine Advisory Committee, Dr. Pan, for your information. And then welcome to Dr. Aragon. He stepped into a seat that I believe is hot, but he knows how to have asbestos in his pants. So I believe that he will handle it well. We know he will. Thank you for taking on the role that you have as the CDPH director. So what we will look at now will be the recommendations B and C, phase 1, B and C. Phase 1A is already on the books and in action. We are working very hard to ensure that we get those vaccinated. I appreciate Dr. Pan stating the goal of 1 million in the next 10 days. That is a goal that can be met and we hope will be met. Vaccines don't save lives, vaccinations save lives. So we got to get them out of the refrigerator, freezer, and into those arms. I will note that in addition to what Bobby Wunsch mentioned, and thank you, Bobby, for your update with the comments from the public, that we received 4 letters directly from you all, from the CVAC, California Teachers Association, disability groups twice, and then Health Access. So we do get that information and we review it and we take it to heart. So thank you for submitting your information. What we'll discuss, as I said, is phase B and C, 1B and C. We will note that when you hear it, if you haven't gotten it directly from the governor already or reviewed that it will directly reflect, again, what the Surgeon General said, your suggestions were. It is excellent that your suggestions aligned with what the drafting guidelines had in mind and what the ACIP had in mind also. So it's almost people with like minds coming together. And again, based on equity, transparency, excuse me, and the exposure and the workplace. So that's very much appreciated. So I'm going to turn it over to Dr. Schechter to give the report. But before he comes in, Tricia Blocker will give a report on the impact of federal funding on vaccine distribution in California. So we'll go from the federal perspective to the state perspective. So Tricia, please take it.
Not sure if Tricia was able to make the meeting today. And Erica, I don't know if you wanted to say any additional.
I can't hear you. Bobby, we can't hear you well.
Oh, sorry. Can you hear me now?
A little better.
Erica, do you want to say any other words about the federal funding? I know you mentioned them in your opening comments.
Yeah, I think those are the main points I wanted to make in the opening comments.
So then I
All
think
right.
afterwards we can go on to Dr.
All right, so then we'll move on. That's fine. So then we'll move on to a very important aspect, as I said, the update on the vaccine allocation distribution. So Dr. Schechter.
Thank you, Dr. Brooks, and greetings to you all. Happy New Year in these difficult but hopeful times. So I just want to briefly talk about the guidelines for Phase 1B and Phase 1C, as announced by Governor Newsom on earlier this week in his press conference. And these should look very similar to our discussions over the last weeks, with a few changes. Similarly, there's a lot of overlap between the state phases and the national ones reached by the Federal Advisory Committee on Immunization Practices, with some notable differences as well. So for Phase 1B is broken into 2 tiers, with efforts starting for Tier 1 and then proceeding to Tier 2. And Tier 1 are persons 75 years of age and older. And then California essential critical workers with at risk of occupational exposure in 3 sectors: education and childcare, food and agriculture, emergency services. For these four groups, either by age or occupation, there's the drafting work group and the guidelines. There's no ranking within the 4, unlike some of the tiering and ranking in Phase 1A. So all 4 seen as co-equals in efforts to reach and immunize them. In Tier 2 are in an expansion of our last discussion, I think in front of you, and the proposal since that time has gone to all persons aged 65 years of age to 74, as well as additional critical sectors, including transportation, industrial, residential, commercial sheltering facilities, which includes construction and a number of other occupations, and then critical manufacturing. Also included are certain congregate settings at high risk of outbreak and spread of disease, including incarcerated individuals and sheltered persons experiencing homelessness. Next slide, please. For Phase 1C, there are also some adjustments in the age groups included in Phase 1C, including both by age and underlying medical conditions or disability, which increase risk of severe COVID disease. So the age cutoff now is 50 to 64 for Phase 1C, and then persons at the minimum age for immunization, which is currently 16 years, through 49 years, who have underlying medical conditions or disabilities which increase their risk of severe disease. The remainder of the essential sectors listed in the governor's list of 13 sectors are included here, such as water and waste management, defense-related industries, energy, communication and information technology, financial services, chemical hazardous materials, and government operations and community service. As Bobby indicated, a number of questions coming in around where do I fit in the phasing and tiering, and when and how will I get my dose of vaccine? When will I have access? So the next slide is an example from the website of the essential sectors, critical essential sectors, which lists many of the specific roles and for the most part what the drafting guidelines is using is referring to in the eligible occupations and roles. And I think that's the end of my brief slides, but certainly welcome your comments and questions.
I think before we go to questions, Rob, we're going to hear from Ron, and then we'll open it up for questions.
Thank you, Bobby.
Go to the next slide.
Steering things in the right direction.
Thanks, Bobby and Dr. Schechter. Happy New Year to everybody. I have 2 slides to present. These are to update you on some work that we're doing and get some feedback. The first slide is to let you know how we're responding to yours and the rest of the public's increasing demand for information on vaccine eligibility. There are other states that have some systems that they're putting in place: Washington, New Mexico, New Jersey, New York, several states trying to figure out how to push information out as much as possible and keep people informed. When it comes to moving into the next phase, it's a much bigger group of people, much bigger population than what we're seeing in phase 1A. So we're going to be communicating through a number of channels, not the least of which is hopefully all of you on this advisory committee and your organizations and associations. But we've been meeting with health plans and, of course, the health departments and health systems and a number of entities to push the eligibility information out to the people that need it. And of course, the information has to be user-friendly. You're going to be hearing a lot more about the campaign that's coming up at the end of the agenda here today. The occupations in the sectors that Dr. Schechter just shared are on this website, covid19.ca.gov/essential-workforce. And Dr. Schechter, the previous slide showed you what one of those sectors looked like. The example was emergency services. And the bottom line is, if you're a personal care assistant or attendant, you need to know whether you're eligible. And, for that example, you fall under the healthcare sector and you're in phase 1A. We've talked about farm workers. They're in food and agriculture, so they'll be in phase 1B, tier 1. In terms of eligibility determination resources, we do have our COVID-19 hotline, which is 1-833-422-4255. There's an email box there as well, which is COVID call center, all one word, at cdph.ca.gov. We're also exploring the possibility of an online tool. There's a team just starting to look at some tools from other states where you could actually go online and answer a few questions and know immediately whether you're in the eligible phase at that moment in time. So that's something that we're exploring and you'll hear more about as we learn more. Next slide, please. We also, of course, want to make sure that the vaccine is getting to the people who we have prioritized and the people that truly need the vaccine. So as we start moving into these phases with much bigger general public populations, we want to be able to monitor equity in the vaccine coverage. So we're looking at what a vaccine equity metric might look like. And right now we're contemplating using the Healthy Places Index, which you have heard before. We presented information on the Healthy Places Index during our development of the Phase 1A allocation framework. And what we're looking at is comparing the percent of the eligible population vaccinated in vulnerable communities to percent vaccinated in less vulnerable communities. And that determination of vulnerability, again, is using the Healthy Places Index. The benchmark we're considering for what we would define as success is equal coverage, i.e. no disparities across those communities. So this is my last slide, and I'd love to hear from the committee members about whether you feel like the Healthy Places Index is the most appropriate measure of vulnerability to monitor equity in vaccine coverage, and if not, what other equity measures you might recommend, and then whether or not you agree that equal coverage is an appropriate benchmark for quote unquote defining success. That's the end of my slides, and I'll turn it back to you, Surgeon General Burke-Harris. Thank you.
Thank you so much, Dr. Chapman. And so we heard a number of things, and I want to highlight there are a number of questions that came up in the chat as well. But for now, as Dr. Chapman mentioned, we want to hear from you, particularly around this question of the equity measure, the vaccine equity measures. How do we measure that? And if whether or not the Healthy Places Index sounds to folks like a thoughtful measure, or whether folks might recommend some other potential metrics and have suggestions that maybe either we hadn't thought of or we hadn't. I'm sure our team in the Department of Public Health has certainly thought about it, but just to hear your thoughts on the pros and cons.
Thank you.
So I know a couple of people have their hands up, but you had your hands up before the questions were posed. So I'm gonna, if you have answers to the questions, we'll start with you. If your questions are about other issues related to vaccine distribution, if I could ask you to hold off just for a minute. So Charles, is your question in response? I'll come back to you. Deborah, is your question?
Yeah, mine's on another topic, so I'll just add my comments to the chat.
Okay, great. Or we'll come back to you. So any feedback to Dr. Burke-Harris and Dr. Chapman's question about how do we look at equity in terms of vaccine distribution? And is the Healthy Places Index the metric that we should look to, or are there other thoughts that you have about this issue? Okay, Sylvia, we'll start with you and then we'll go to Kieran. And please introduce yourself so all the members of the public know who you are and your organization.
My name is Sylvia Yee. I'm with Disability Rights Education and Defense Fund. And I think that the index will work for a number of factors. I do not think it works very well for people with disabilities. And in particular, I think that the ordering of this, the degree to which people with disabilities have exercised their civil rights winds up working against them. When they've exercised their civil rights to be in the community instead of in a nursing home, it's been working against them when it comes to vaccination. And part of their civil rights has been the very strong desire to live in integrated housing distributed throughout a community, not to be in a particular place. And that has resulted in scattered housing. I think there is a correlation that a lot of people with disabilities find that their only options are in lower income communities, poor housing, et cetera, and those people should be vaccinated and will be included and addressed. But in some parts, I don't I don't think that the places index will reach a very disproportionately affected populations in terms of disability.
Thank you,
Thank you.
Sylvie. Let's go to Karen and then Christina and then Anthony.
So this is Karen Savage, California Pan-Ethnic Health Network, and Sylvia's point is well taken. I do think the Healthy Places Index, though, holds value in terms of identifying particularly historically and currently underserved racial and ethnic linguistic communities, although it doesn't actually use race and language. And so there are other measures that do incorporate race and language, but I do think because the state is already using Healthy Places Index in the reopening, it might make sense to stick with that. So we're identifying sort of the same places for these sort of different processes and issues. I don't agree with the sort of benchmark of success, I think it was called, in terms of equal coverage or equal distribution. And this is where I think it's important to remember there's a difference between equality and equity. And I think it would be more equitable to look for a vaccine distribution that is actually aligned with the COVID, both transmission and death rates in the communities. I think saying we want to have communities that are much harder hit by COVID have the same vaccination rate as communities that have not been hard hit by COVID, in my mind, that's not equity. It's equality, but it's not equity. And I think we're striving for equity here. And so I would encourage the benchmark for success to really focus on equity.
Thank you.
Thanks.
Hi, everyone. This is Christina from the California Foundation for Independent Living Centers. Yes, I want to agree with Sylvia, and I don't want to speak on behalf of all of the disability organizations here, but I think that for the most part, we would all agree that that index would not be an equitable tool to use in making sure that people with disabilities are included. Secondly, and this is more to the reality of implementation, is there any way, it feels like there's a disconnect still between what's happening on a statewide level and what we're suggesting and advising on versus what's really happening on the ground. And I'm just wondering, as we continue to have these really important discussions, how are we ensuring that implementation is happening in the way that we are working towards trying to make happen during all of these meetings?
Thank you, Christina. Ron or Rob or Erica, is there anything you want to say in response to the last point that she just made? In terms of tracking implementation according to the guidelines?
I can take a first pass at that. I think, this is absolutely something that's really important to us at the department and the state level. And I think along with some of the challenges on data collection, related to the many of the things we're talking about that we all care about, I think we are looking at this as well. And how do we collect data so that we can track this well? I think we're taking a first pass at that. As far as what's in our immunization registry, a lot of the pros and cons of what have happened over time with our immunization registries is there a transfer of records between electronic health records and the immunization registries. So the good thing about that is we're not doing manual data entry anymore, but there's less control over how that data is transferred because they're very standardized across electronic health records. So we're working on solutions for various aspects of data collection to track, and then we're also surveying, and actually our first survey right now of local health departments and local health jurisdictions is really looking at kind of what are their needs to improve and accelerate vaccination, but we're very much, as Dr. Chapman mentioned, interested in the sort of equity metric, and we're going to talk a little bit about that in the next section too, as far as how this is getting implemented at the local level, and then how we're also tracking that. And I think really importantly, to your point, how we continue to get good information out, to all of our different stakeholders and partners. So an ongoing work, and absolutely appreciate all the feedback and input on that process.
Thanks, Erica.
I'd like to, can I just to ask a clarifying question? We're definitely hearing to Sylvia's comment around the HPI index, whether or not that is the appropriate tool for assessing perhaps risk for the communities with disabilities. one of the questions is there kind of another tool that folks would recommend? And I want to understand, Sylvia, are you thinking about reaching folks with disabilities, or are you thinking about understanding the degree of risk, right? So one of the things that we understand about the HPI tool is that we do have some data around the assessment of what is the COVID risk for individuals at different HPI quartiles, for example. So we're looking at the rate. So are we thinking, how are we thinking about that? And what do we think might be a better tool for assessing risk for individuals with disabilities?
I'm unmuting myself because I think that was a question to me, to
Yeah.
Sylvia. Okay. What's so hard about this is that there's been such a data lag around disability, and we've talked to doctors and we've talked about like trying to figure out what are the risks for people with specific conditions, for people with significant disabilities, for people who are taking medications, and there's this, well, don't know, and it's not that I blame anyone. It's a novel virus. But then the data that we're relying on to figure out who is to be prioritized is data that is notable for the absence of risks to people with disabilities. And I think that has affected this group and affected prioritization. And, you know, I don't have a tool that will make up for that lag, except that, I mean, gradually we're getting more information about people with intellectual and developmental disabilities, for example, and the kind of risks that they have of more severe illness. And I mean, some of it is just that we know who is living in the community with significant disabilities. We have an idea of people who are really have disabilities and are at risk of death, whether from COVID or 19 or something else, because they can't get to a hospital and can't get their treatments. I mean, that's the tool, I guess. If we can have some idea of that and prioritize them. I don't know if I can come up with another tool to assess how to find them.
Okay, thank you. Thank you. I just wanted to offer an opportunity to clarify. Sorry, Bobby, go ahead.
No, that was really, I think, important. And I think there are a few comments in the chat about other ideas about how to address the issue. And if others have more ideas, please put them in the chat. Let's go to Anthony. And then I know that Lance Hastings had a question early on, and Charles, so did you, and so did Denny. So let's try and see if we can get through those before the next agenda item. Go ahead, Anthony.
Thank you, and thank you for both the opening comments and all the information provided. I want to support Kieran's comments with regard to equity and equality and the Healthy Places Index is a metric we have. I also do agree that other metrics are important, and I do think we are constrained by two factors. Number one is what data exists, because there's lots of things that we would like to do, but just there's no such data set. And then two is how would we rectify it if we do find that there is an issue, and like what is our remedy? And so one thing I would potentially suggest is, and I would like to see that if we are, and I'd like to focus on the issue of the remedy, because it's not good enough just to collect the information and know there's a problem, but we'd also like to know, like, okay, if something triggers, what are we going to do about it? And so, like, the thing that is useful about the Healthy Places Index is that if there is a region that is underserved, especially given its risk factors, then I would like there to be in 1C or wherever it fits in the hierarchy, some allowance for the public health officer to do aggressive regional efforts, site-based efforts, and allowance for greater vaccinations in that area. And if it's just about collecting the data, then I'm not sure what the point is. So I'm assuming that there's a remedy piece of it, but then we should make that clear. I do think that another way to do it, the data we might have, is if we are getting information from the contact tracing or from ICU use, that there are outbreaks happening in certain situations, and certain efforts, whether it is multi-generational housing, apartment buildings in certain areas, et cetera, that then again, that then the public health officers have an ability to then, do that apartment do these apartment buildings that fit these criteria or whatever is possible. But I would say we do need to, it would be helpful to sort of do that in comparison to both the data we have and also the remedies that we have available. And that's my last point is just to come back to these very practical questions that Christine and others raised, which is, I appreciate the slide on vaccine determination that we'll be getting the message about who is eligible, but I still haven't heard who decides, am I eligible? Is it the worker? Is it the employer? Is it the public health officer? How do I get the data? How does the pharmacy or the clinic verify that say who I am? And because I do think that has a huge impact on equity if the well-resourced or the well-connected can get in and others that are maybe less connected can't. And I would just welcome if there's further clarity on that direction. Thank you.
And Anthony, I think we'll be able to answer some of those questions in the next section on the agenda when we'll be talking with Eric and Kim from the counties and how they're approaching those issues very specifically. Lance, are you back? Lance Hastings?
I am.
Good, great, go for it.
Can you hear me, Bobby?
Yeah.
Okay, thank you very much. Appreciate it, particularly at the front end with Dr. Pond's comments about training more people to administer the vaccine. And one thing I'd like to get onto the table is the larger employers in the state that are already equipped with health professionals on staff, that we can assist with large scale vaccinations when we get to our sections within 1B, that we can help enable that system. And I just wanted to convey that, make that offer, and get it known that within the manufacturing community, we are well positioned to do that and offer some assistance. So please have that on the record for the conversation.
That's great. Thank you, Lance. Charles, why don't we go to you next?
Thanks, Bobby, and thank you everyone for all your hard work. I'm going to go ahead and pause
Charles,
my questions.
could you speak up a little?
Yeah, thank you. Can you hear me now?
It's still a little faint.
Okay. I'm going to just go ahead and go on mute. Okay, Bobby, I pass.
Okay. Okay. Let's see. I think we'll go to Maria Lemos and then we'll go to Denny Chan.
Thank you, Bobby. I wanted to just get a little clarification. I did go to the COVID-19 website and where it says community health workers, public health / and my concern about that is not enough detail, because I do see where in many places clinics and plans are vaccinating community health workers that they hired. But there are hundreds and hundreds of promotoras who are working with CBOs doing frontline work. They're working in food distribution, they're working in outreach, and that they have not, I know that they have not received anything or are in the mix. And so I'm concerned that they're not in there because it's a community piece and they don't necessarily fall under the community health worker description. And how can we remedy that?
Great question, Maria. Thank you for bringing that up. Let's go to Denny. And please remember to introduce yourself and your organization so the public knows who's talking. We all know you, but we want everybody else to too.
Thanks, Bobby. Hi, everyone. Denny Chan from Justice and Aging. Happy New Year. I had one comment and then two quick questions. My comment is about equity with respect to what's been proposed for 1B. I think it was during the announcement or during the presentation that someone said that there's not really a sub-prioritization among the different occupations and older adults who are 75 plus. I really hope that we think about equity when we talk about sub-prioritization. So even if we haven't sub-prioritized specific occupations, but that equity is still a factor. I really appreciated that we were able to come to that agreement in 1A, and that we're able to use sort of an equity lens to be able to dole out the allocations when appropriate. So I really hope that that's at least made clear, even if there aren't specific occupations or age bands within the 75 and plus group, that is clear that equity is still a metric. I think I said before at our last meeting that for older adults, not all older adults are equally at risk. And so it's clear that older adults and communities of color are disproportionately at risk, and that needs to be a factor in how we think about the allocation, particularly in light of Secretary Azar's comments today, encouraging that, if there's leftover vaccines, that it should be that local health departments should be sort of administering them as quickly as possible, because when that happens, things like implicit bias really do creep in. So that's my point about equity. My two questions, hopefully can get some quick answers. One is, there was a hotline that was presented. Who is staffing that hotline? What are they taking calls? Like, which phase am I in, and how are they answering those calls? Are they just using the guidance that has been released so far? So any color that we can shed on that would be extremely helpful. And then two is for phase 1C, with respect to people with disabilities and certain chronic conditions that put them at higher risk, how is that being operationalized? Are we using what the CDC has delineated, or is California coming up with a separate list? So the two questions, one is on the hotline, and two is on defining the disabilities and chronic conditions for higher risk. Thank you.
Thanks, Denny. Why don't we start with Ron answering the question about the hotline, and then we'll go to Rob Schechter about both your point about phase 1C, but also to answer or to clarify how 1B is integrating the equity subprioritization. Ron, could you talk just for a minute about how the hotline's being staffed and what kind of questions are they receiving?
Sure. I've actually called the hotline myself to check on vaccine eligibility. So I know there's a live person waiting there. This is the COVID call center. So it's basically state staff that are there to answer a lot of questions about COVID, not just vaccine, but there is a number you push to get answers about vaccines. And so you talk to a live person and you can share with them, what kind of work you do, and they tell you what phase we're in now, what phase is coming next, and what sectors and workers are in those phases. It doesn't have a level of specificity. If somebody calls in with a challenging job title, for example, or occupation, they might get referred to figure that out, so to speak. But I think they'll be able to answer a good percentage of questions, but that's why we're working on a number of resources. I mean, we're talking about, possibly posting a much more comprehensive list of job titles and occupations. We're exploring this online tool. I think we're going to need to have a lot of different mechanisms for answering people's eligibility questions.
And in terms of the hotline, just a quick follow-up question on that, because I remember Jeffrey had asked a question that I thought was really important. I'm assuming that the state workers who are staffing the hotline are speaking at least the Medi-Cal threshold languages to be able to take callers with limited English proficiency.
So I think that's required by law. I don't run that call center. I'm not involved with it, but again, I did call it. And in the beginning, there's a lot of languages that are spoken. So there are different options that way, but I'm pretty sure it's required by law that we do that.
Okay, well, the test will be for all of you to call the hotline and
yes, in many languages. Thank you.
To us. That'll be very important. Thanks, Ron. Rob, would you mind clarifying the phase 1C populations, and then also how the subprioritization is going to work in phase 1B, where there are tiers, but the tiers aren't in priority order of which group gets the vaccine first.
Thanks, Bobby, and thanks for the questions. So along with the skeletal outline of which groups are eligible in each tier and phase, there will be additional guidance with some parallel language to what was in 1A about subprioritizing at the site of either during the allocation decision or at the site of where vaccine is being provided on available information on similar sort of risk factors or criteria that were included in 1A, including level of occupational risk underlying conditions or age, race, ethnicity, residence in a vulnerable community. So using those similar criteria for subprioritization during scarcity. For phase 1C, where the underlying medical conditions or disabilities, currently we are pointing to the CDC list of associations of factors associated with higher risk conditions and disabilities, which is an evolving list, but also appreciate that that there will be, as folks are going to their medical providers or the regular sources of immunization, as vaccine becomes increasingly available, that there was clinical judgment or clinical discretion in making those assessments.
Thank you so much, Dr. Schechter. And now, as we are at the time on the agenda, we're going to take a moment for a short break. So we will take a 10-minute break. And when we come back, we will have the opportunity to have a conversation with leaders of our local health departments to and continue the discussion from our last meeting around how this is really being deployed on the ground. In that conversation, Maria, we will not forget your question about Promotora, so we can jump in with that question out the gate when we hear from our local health directors. And as we head into the break, we want to remind everyone to mute your lines and turn off your cameras. And we will see you back here at 4:15.
Okay, I think it's time.
All right. Yes, it looks like we're back. There we go. And now in our agenda, so welcome back. I hope everyone had a restorative break. And now in our agenda, we're going to continue our conversation from our last meeting with our local health leaders about operationalizing the distribution of vaccines on the ground. And we have with us this afternoon, Dr. Eric Sergienko, the health officer for Mariposa County, and also a representative from the California Conference of Local Health Officers, the CCLHO. And as well, Kim Saruwatari, who is the director of the Riverside County Public Health Department. And she's also a representative of the County Health Executives Association of California, CHEAC. I want to welcome them both and open a conversation about and invite them to hear from them about the distribution of the vaccine on the ground. And there were two questions, Eric and Kim, as you are teeing up your comments that I want to make sure that we're responding to. One was Maria's question about the promotoras and where promotoras sit in the process, whether they're considered community health workers. And then there was another question about truck drivers and where truck drivers the distribution of vaccines, what is that allocation or distribution process for reaching truck drivers? So I'll lift those questions up to the discussion and turn it over to Eric and Kim.
Great. So good afternoon, everyone, again, and good to be back. And again, taking copious amounts of notes because, again, recognizing that the work that you're doing is critical in informing how we at the local level will get, do that final step of getting needles into people's arms, because that's really where it's happening. If we can get vaccines into the field, that's a great thing, but it's that last step that's most important. So the question about promotoras, I will direct folks to the CDPH webpage, which talks about recommendation B1 subprioritization by type of facility or role. And promotoras are actually called out in tier 2 of phase 1A, along with all community health workers. And that's regardless of the sector. So if they're doing work with CBOs and not necessarily with health departments or some other closely aligned with someone who's doing vaccinating, they are in that tier. And the challenge would be is if we have not reached out to them, ensuring that linkage occurs between the CBO and the vaccinator. And I think that's really the challenge for all of these things, is making that connection. I think that's the valuable part there. And then the other question, which I rapidly forgot.
The second question was about truck drivers.
Truck drivers, I think Ron talked about those in the phase 1B or 1C. I'm going to say 1C. And the only question I would have there, or not the question, the thought I have back is, and Ron has talked about this before, is think about not in terms of actual individual roles, but rather the sector in which that person works. And so if you have a person who's a commercial driver's license as a truck driver, but is working in food and ag, that person might actually be more in that sector than in the 1C. And so that's, I think, some of the nuance, and I don't know if Ron is still on and wants to comment on that, but recognizing that when you look at some of these positions, that they are not necessarily job descriptions, but sectors in which they work. All righty. I don't know if Ron is still on.
I'm still on.
Did I say that correctly?
Yeah. I'm not sure what I can add at this point.
Okay, cool.
I
Yeah,
think the truck drivers are in 1B2 under transportation.
right. Yeah, you got it right there. But I think the question is it's sector driven and not necessarily individual role driven. And so as an example, a bus driver who does school buses would actually be not in transportation, but in education.
Good point.
So, all right, did that address the question? Or we can loop back to it. We got time. All right. Again, good afternoon. And I think, Bobby, if you want to just next slide, I think this captures all of our discussion to date. Is how will I as an individual or as a sector know when it's my turn to get vaccinated and where will I go to get it? And if we solve that problem for everybody, this is an easy thing, but we know it's not. So, but we know that is the overarching question, and we're keeping that in mind as we try and solve what is a huge distributive and logistics problem, along with having adequate staffing, supplies, and systems in place. Next. We did get a number of questions, and thank you to Bobby for digging these out for us, going through all of the conversations that we've had over the last several weeks. In addition to Kim and I, Erica will answer some of these as well, because we do recognize it's a partnership between not only the state and the county, but the federal government, the states, down to the counties, down to those multi-county enterprises or entities that are distributing vaccines, down to the individual clinics, down to those people that can help us augment and reach into those populations. So she'll answer some of the questions. I'll answer some of them. And Kim will answer some of them. So with the long-term care facilities, what we do know now, and actually it's gotten pretty regular now, is the COVID vaccine task force at the state has been distributing spreadsheets of dates to the counties and also notifying the individual long-term care facilities. And that does include both sort of broken down into two categories: the skilled nursing facilities and the assisted living facilities. And that notification has gone reasonably well. I think we've got another slide here about talking about how well it goes. And when we get to that slide, we'll talk a little bit more about how it's actually rolled out over the last week in a number of our skilled nursing facilities and give you some feedback on that. With informed consent, I'm going to defer that to Erica if she's got a good answer. But at this point within my facilities, we've been able to identify persons that have that durable power of attorney. And I think that's been fortuitous. We've not had to work where we've had sort of an implied consent situation.
Yeah, I think all I would add is that they require consent similarly to any other medical care that's provided in that facility. And so they get consent from patients or those who have legal powers of consent for them. And again, it's a precaution required, that isn't required by federal or state law, but want to make sure that there is some form of consent. And we do understand it is paper-based, so there are some challenges to that. But I think, there are pros and cons to electronic consent as well, as far as being clear that that's, a validated consent.
Eric, maybe I can just jump in here to give a little bit of what we're seeing in our county, just to give everybody a flavor of how it's working. So I'm from Riverside County. So we have weekly calls with our skilled nursing facilities and long-term care providers. And so pretty good dialogue in terms of feedback. All of our skilled nursing facilities in Riverside have been contacted and clinic dates are set up. And we've had first visits for 29 of our 58 skilled nursing facilities. 22 of those have been with CVS and 7 with Walgreens. So things are moving forward. One of the big lessons that we've learned is just that we need to have identified 2 to 3 deep people at each facility that can assist with the coordination, particularly somebody on site that can help with that, because the logistics and the paperwork is quite a load. And I think Dr. Pond mentioned this, that it is manual paper. And so that makes the paperwork piece of this pretty labor intensive. But in general, the process is moving forward and we are starting to see this population get vaccinated now.
And I think there was a question about Part B for the assisted living facilities. That's going to start next week. So it's been activated and it's going to start next week.
Thank you so much. I want to pull up a question that was in the comment previously. I think Mike Dark asked the question, how do we know when we're moving from one phase to the next? And it sounds like you touched on that, but if we could maybe be a little, speak specifically to that question.
So I was going to say that's going to be our very last slide. So dramatic foreshadowing.
Right.
But we will talk about that. So yeah. All right. Next slide, I'm going to say. And Kim's going to talk more about this because, again, she's got a much larger jurisdiction than either of the two that I'm health officer for, and how to do sub-prioritization.
And I think, Eric, Dr. Pond, did you want to start that off and then I'll chime in?
Sure. Yeah, I wanted to, in the document that Dr. Sergenko referenced, and I put the link in the chat, during the current phase 1A recommendations, there are, in that guidance, it talks about sub-prioritization and thinking about on the facility level, making sure that if there are inadequate doses to reach everyone, that actually the priority is given to facilities that serve the greatest proportion of vulnerable persons in their catchment, in their area, as measured by either the Healthy Places Index or a comparable health department knowledge, followed by facilities serving fewer vulnerable persons. So, that is that guidance in there. And then I think Kim, can talk to more how like Riverside is using this Healthy Places Index. We're again working on kind of surveying as well and how that's going. And then I'll just jump in for this moment too and say that at the state level, as we're thinking about supporting the local health departments and local communities, we're certainly looking at the HPI on the statewide level as well. So during the health equity metric for the blueprint, for example, that's been within a county, but we're also thinking about this and using that map statewide to think about where the most resources are needed. Absolutely. So, and we appreciated the input all of you had earlier as well. And one other quick thing, a little bit off topic, but I just wanted to say earlier, I thought the governor had already had his press conference. And I think a lot of the key points he was going to mention, I did mention, and I think it was postponed because of the other situation in the Capitol. So that has not happened. You all were the first to preview some of those key points. So I'll turn it over to Kim, though, to revert back to Healthy Places Index. I just kept forgetting to mention it. Thanks.
All right. Thanks, Dr. Pond. Just briefly, so we are using the Healthy Places Index in Riverside County. We actually are monitoring positivity right now by each of the zip codes and the tracks in the lowest quartile. And so we are doing very specific testing in those lowest quartile zip codes. And just as unfortunately we've come to learn across the country, we're experiencing positivity rates up to like 41% in some of those areas. They're very, very high. And so we are working as part of kind of using that umbrella context of the Healthy Places Index. We're working with the Catholic Church. I think I mentioned that last time because they have a very, very large footprint in much of our county. And then other faith-based organizations as well. But then with our community-based organizations. And so Maria, just to add on to the answer that Dr. Sergenko gave earlier, we are actually vaccinating promotoras and community health workers this week. And so what we have done is we've reached out to the CBOs that we regularly work with and even those that we don't, and asked for a list of promotoras and community health workers so that we can reach out directly to them and share the clinic dates and times with them. So that is happening in our county locally because we recognize the fact that they are out on the front lines. We're asking them to be there when we're doing testing events, and we're asking them to spread the message about vaccination and get the community excited about getting vaccinated. And so we're vaccinating them consistent with phase 1A. So that will be happening this week. So that's.
Thank you. Can I just say that I wish that I would hope that the state would look at that as a model and would suggest that they do that across all counties, because this is a big issue in many of the Central Valley counties and the Bay Area and the coast. But thank you for that.
Yeah, absolutely. Absolutely. So that's kind of how we're using the Healthy Places Index. And then in addition to that, we have our own equity committee locally that's comprised of CBOs and universities and other groups that we regularly partner with. And so we're looking at equity as we are developing our vaccine plans and rolling out vaccine. And I think we could go to the next slide, please.
And actually, we've drilled down on a couple of these already. But yeah, I probably, if you'll remember back to when we talked last time, is every local health jurisdiction has some differences in how they do their outreach, and I like the idea of sharing best practices and learning from successes. But we've been using, for those independent practitioners, what has been successful for us is outreach through social media and outreach through professional societies. And then, sort of lowest common denominator is using our call centers, and then being able to take those calls and route them to the vaccine teams so that we can align the persons that are fitting into our Tier 1A right now, our correction phase 1A, and making sure that those people get the vaccine. So having as open a system as possible. And again, I think I mentioned this last time, is with our IHSS, we've even had to go US Postal with them because some of them don't even have access to internet. One of the questions that came up from the CVAC, behavioral health workers at risk. Yes, I'm doing outreach with them in the counties that I'm working with. I don't know, Kim, I'm assuming she's, same there. Is that, if someone is a frontline healthcare worker, including behavioral health, that's critical for us. And then last bullet, personal care attendants, is that we've been treating them as IHSS-like workers. That is, they perform the same scope and scale of work. And so while notification has been a challenge, I've considered them eligible.
And as you probably have gathered now, so Dr. Sojenko gives kind of the big picture, and then I dive into the details a little bit. So just to kind of give you an idea of how we're thinking of the vaccination campaign at the local level, we're thinking of it in 3 buckets. So we have the provider bucket, where we're leveraging providers as they are approved to distribute vaccine to vaccinate their own staff in the appropriate phases. So healthcare workers right now. And then as we move through the phases, they would be able to vaccinate more. So that's one bucket, is the existing provider network. The second is the points of dispensing, or pods. And so that's where we're partnering with schools, nursing schools, PA schools, pharmacy, whatever we can get to partner with us to staff those pods and making those available throughout the county. And so we launched that actually today, was our first pod for phase 1A. And then the third bucket are our community vaccination teams. And so those are teams that will go into areas that we feel would not be coming to our pods for whatever reason. Either they don't have schedules that are conducive to that, or they don't have transportation. And so we'll be sending teams out into the field. So one example is, it's much easier for us to send a team to some of the growers and vaccinate farm workers than to ask them to come to us. So that's kind of how we're thinking about vaccination. And Dr. Sojenko mentioned using the medical association, the dental association, any of the associations that are out there where we can get consistent messaging to different groups we're using. But we also have a whole group of people that are literally combing the internet for all the different home health providers, all the different urgent care providers, and coming up with lists. And then we're reaching out from those lists. And some of that is labor intensive, but we want to make sure that we're being as complete and comprehensive as we can. And then just another example for the IHSS part. So we met with our Department of Public Social Services, which is involved with our IHSS workers, as well as UDW. Matthew Maldonado on the committee came in and, well, virtually met with us as well. And so we were able to talk about our 33,000 workers and how we are in the process now of surveying them. We're going to be sending out messaging both through social services and working together to make sure that we're vaccinating their folks. UDW was able to provide amazing data about density of IHSS providers throughout the county by zip code. So that was also really helpful. And then personal care attendants in general, we're working, reaching out to home health agencies so that we can identify care providers and things like the Inland Regional Center, which is kind of an overarching umbrella that works to get personal care attendants for clients. And then we know that there are those independent care practitioners out there that are not part of a network. And that's really a big challenge in terms of how do we identify those and reach them, other than the ways that Dr. Surjenko already described through social media, our website and different things like that. So. I think we're ready for the next slide.
All right. So with the planning that we're doing for our eligible people, we're building out registries, and I know that at the county level, numerous counties are doing this, whether it be on a Google form or a Microsoft form or some other sort of database, and using that same outreach that both Kim and I have mentioned to introduce people to those registries. And at least for the counties I'm working with, the intent is to do individual scheduling once they're in the registry based upon the information they put in that registry. So as much as possible, we want to schedule vaccinations, recognizing that one of the logistic hurdles or one of the things that we need to consider in administering this is you have to observe people for 15 to 30 minutes post-vaccination. And so you actually need the physical space to observe people. And that's some of the hiccups that we have found in the first couple of weeks of vaccination is you can't run people through these as fast as you do with mass vaccination clinics for influenza or other exercises that we've conducted. So it needs that level of scheduling. Another question was, how will CBOs, CVAC members, and other trusted messengers be utilized by the local health jurisdictions? Trust me, you will be. And if you're not, I know that Bobby shared contact information for both the CHIAC membership and for the CCLOJO membership. So you're both your health officers and your health department or health and human services agency directors. And so if you have not heard from us, we would love to hear from you. And Mike, Kim had asked if you could get my email, and I'll just put it in the chat box. And anyone who wants to reach out to me, by all means, but more important to reach out to your local health officer or director. The other point of contact that I think is critical is that Joint Information Center or call center. If you can't get a hold of one of us in the senior leadership position, my JIC lead sits 20 feet over there, and she does not hesitate to get a hold of me if there's a reason to get a hold of me. And I think that's true for any of the health officers or directors. And as usual, Kim will fill in all the blanks that I've managed to skip over.
Dr. Surjenko, I think you handled that slide perfectly. I wouldn't add it.
All righty, so let's go to the next one. And it's, how does a local health jurisdiction or local health district department know when it's time to move to the next phase or the next tier of a phase? And really it's a feedback loop with both the state as the supplier of the vaccine and with the vaccinators who are out there vaccinating people. And I have a smaller feedback loop than a large county. And so recognizing, well, how many more people do we need to vaccinate within that current tier or tiers, recognizing that we may be, with phase 1A, looking at how do we do tier 1 and tier 2 at the same time, or tier 2 and tier 3 at the same time. And so thinking what's the unmet need there based upon feedback from our vaccinators and working with the supply we get from the state. And then one thing we did recognized when we started vaccinating is there was a preference on some of the healthcare workers to receive the Moderna vaccine over the Pfizer vaccine. So although we got the Pfizer vaccine first, there were some vaccine hesitancy over that. But then when we came back with the Moderna a week and a half later, that we had some new takers there. So we always have to go back to the previous tiers and say, are there any takers for a different vaccine or vaccine product, or have they addressed their concerns and are now ready to get vaccinated? So if all those demands have been met for the previous tiers, then we consider going forward into the next tier or even the next phase. You know, we're sort of incipient phase 1B here in Mariposa. And so that requires coordination with the state and with our adjacent local health jurisdictions, because we do not want to get too far ahead of our neighbors. We want to make sure things are happening in an equitable fashion. And making sure that the doses are going to the right place, meeting the right needs, and that everyone has the right resources to get things done. And then, you know, as we think about those additional doses, as we move more into CalVax and away from going into the health department, then coordination with the vaccinators on that ordering of new doses. So it's really not how do we know because the state's telling us, or how do we know because the feds are telling us. It's really that feedback loop with the local communities and recognizing that we've met the demand for the current tier and then being able to move into the next tier based upon available supplies.
And I think the only thing I would add to this, Dr. Sarjenko described that. I think that feedback loop exists whether you're a small county or a large county. The loop is just varies in size, right? But I do think, you know, across the state, our goal is to get vaccines safely into people's arms as quickly as we possibly can. And so as we are moving through this, we are getting faster and, you know, identifying the logistical challenges and ways to overcome those challenges. And I think that it is only going to improve as we move forward. And, you know, ultimately our goal is to make sure that we are leveraging that traditional infrastructure that we use for vaccines and the providers that regularly vaccinate folks. We want to get vaccine into their hands when at the appropriate time when they can vaccinate according to the phase that we're in and really utilize that infrastructure. So that's dependent on the amount of vaccine that we have coming in, but that ultimately, those are our two big goals as we move forward.
And just one last comment from the state perspective, I think, you know, just to kind of reiterate how important all of these partnerships are and these feedback loops. And I think from the state level, and I think, you know, we've all learned so much on an ongoing basis in this pandemic. And as Dr. Sarjenko mentioned, you know, many people in healthcare centers and certainly local health departments have done mass vaccine clinics, you know, for various things, flu clinics for sure, and sometimes for things like meningococcal vaccine. But there's just new challenges that have shown up that people were thinking about, but the devil is always once you actually start. And so I think it's really great for you all to hear some of the nitty gritty things that happen that, you know, and the vaccine arrived in the middle of our, you know, huge surge. So a lot of our healthcare system, again, is stretched and in the middle of the holidays. And people are so tired after this pandemic. I think if the pandemic had just hit, everyone would have rallied on, you know, Christmas Day. But I think, you know, so much of our system, you know, and all of you and our communities are so tired of this pandemic. So I think, you know, I think it's been a little bit slower ramp up than many of us hoped, but I think just as Kim has mentioned, I really do think, you know, things are really ramping up. And on the state level as well, as I mentioned at the beginning of this committee meeting, we're also really trying to look at where some gaps are that we can help fill, help provide resources, think about that with the equity lens as well, to get doses into people. So thanks for the community patience on this. And I think, you know, we continue to get better with every step.
Thank you so much, Dr. Pan. And I want to thank Eric and Kim for their leadership every day and doing this very, very, very hard work, and open it up for some questions. I know there are lots of questions in the chat, and we'll try to get to as many as we can. And if we don't have a chance to get to your question, just go ahead and throw it in the chat and we will respond, try to commit to getting a response to you. So, Bobby, if you want to facilitate our discussion.
Thank you. So we have lots of questions, and I want to ask you to do two things. Don't ask 6 questions when you have for one, please, because it just cuts off what everybody else can do. And don't forget to introduce yourselves. So first I want to start with Jake Snow and see, Jake, from the ACLU, if your question got answered or if you'd like to ask it to Dr. Pon or any of the other CDPH staff that are available.
Thanks so much. I really appreciate it. Again, Jake Snow with the ACLU of Northern California. My question is about the information collected about vaccine recipients who get the vaccine through a pharmacy or maybe another private partner. We've seen indications that pharmacies are actually requiring social security numbers or some other state identification number as part of the form in order to get a vaccine. And CVS, for example, has posted a form that includes a requirement of that information. And it says that it's necessary in order to get a vaccine paid for an uninsured person. So two things about that. First of all, as far as I can tell, it's not necessary to get a vaccine to have a social security number. It might speed the process, but it's not necessary if you look at the website for the Health Resources and Services Administration. And then second, some communities might be hesitant to get a vaccine if they see government identification numbers, social security numbers, state driver's license numbers being a requirement on the form when they go to get a vaccine from a pharmacy. So my question is, how can California Department of Health or state departments of health address that hesitance, avoid that hesitance, and ensure that private partners are doing the same? Thanks very much.
That's a question I will need to take back. I think that's really helpful to know. I have been hearing more about other regional pharmacy partnerships that the CDC has started to work on, where there are different things pharmacies are doing. So I think that is important, unless Dr. Schechter wants to add or has other information to share about that. All right, we will come back to you all with that at the next meeting.
Great. Thanks, Jake, for that question. Andy, I know you had a question about transportation services to get vaccines for those who don't have their own transportation or ability to drive. Do you want to ask your question?
Yeah, thank you, Bobby. And I saw Denny responded in the chat that if you're on Medi-Cal, Medi-Cal can help pay for you to get transportation to the vaccine. This question came from the president of my board who's blind, and I think it's an issue that's come up in the blindness community, but I'm sure it actually comes up for lots of communities that have transportation barriers. So I'm just wondering if we've thought about any way to get the vaccines to people or get people to the vaccines when they are encountering transportation barriers, and recognizing that even if Medi-Cal pays for it, in some parts of the state, the transportation barriers are bigger than in other parts of the state.
Absolutely.
That's a great question, Andy, and I want to loop into that. I want to just ping that to our public health officers and loop into that. There was a question about whether IHSS workers might be part of distributing the vaccines possibly to persons in their home. I wanted to ask the question of, are there kind of, because of the cold chain requirements and the desire not to waste any vaccine, does that put limitations on the ability to, for example, distribute vaccines to individuals in their homes?
Yeah, I'll take a stab at that. No pun intended. But
we're all hoping for our stab any second now, Eric. So go for it.
It really does become a challenge for two reasons. One is, maintaining the cold chain. Both the Moderna and Pfizer vaccines have a requirement for a cold chain, even though there is some survivability after the Pfizer's been reconstituted. You have to use it within 6 hours after the Moderna vial's been punctured. I believe it's an 8-hour window. So it makes it a challenge to do operations like that where you're going to door or going to clients. The other concern I would have is that even though it's rare, adverse effects do happen. And if you're in a rural setting or you're in an area far away from EMS, if you have an adverse reaction and you aren't prepared to deal with that, it becomes a challenge. an IHSS provider, as an example, probably doesn't have that experience to deal with an adverse reaction should it happen. So I think getting to Andy's question is arranging for transportation to where the vaccine is being administered is the logistics hurdle. And something that we've been doing in our registry is asking, do we need to support your coming to the vaccine site and making arrangements for that? Medi-Cal does pay for transportation, but there has to be an existing transportation system. So we're actually even building out within our Health and Human Services Agency the ability to do transport. And layer on top of that, that driver has to have the ability to protect themselves, so have appropriate PPE and be offered the vaccine before all of the people that he or she would be picking up.
Thanks, Eric. And Andy, thanks for that important question. Let's go to Heather Harrison. Heather?
Sorry about that delay. Hi, thanks. Heather Harrison with the California Assisted Living Association. Thank you, everybody, for the work here. I wanted to circle back to the discussion about healthcare workers and seniors in congregate settings. We're tier 1 of round 1A. I know the pharmacy partnership part B just got activated and the clinics will start sometime next week. What we're hearing is that what that will mean for the bulk of the assisted living facilities and the residents and workers in this setting is that their vaccination clinics are likely to happen not until late February or even into March. If that is the case, if that's the expectation that the state has, I think we need to talk about how we can speed that up. What other pathways we need to put in place to get vaccines to this population that's been so isolated for the last 9 months.
Thanks, Heather. This is a continuing saga here. Rob, I know Erica had to jump off. Anything you want to add to Heather's or Ron?
Appreciate Heather's concern about delays into the winter. Our understanding is that with the schedule starting next week, that the 2 pharmacies will be trying to reach those facilities for first visits over a period of closer to a month of 3 to 4 weeks. And we'll certainly be watching that closely along with our local health department partners to watch for any delays beyond that. But the current schedule would be for a quicker start and reaching more places sooner.
Thanks for that. Yeah, I think it's important to keep an eye to that. What options are available if we're looking at a month while we start vaccinating other populations? What can we do to bring those vaccines to these seniors and these frontline workers in the meantime so that we're not waiting another month to get their first shot?
Certainly, local health departments are looking at their resources and their options for bringing staff in or getting doses out to those facilities, and are watching that calendar closely as well.
Yeah, I'll volunteer that in Tuolumne, we made the decision with one of our skilled nursing facilities recognizing when they would be on the calendar for Walgreens CVS to do their work there, is that we identified the more at-risk clients within that SNF and then the healthcare workers, and went ahead and used the county distribution to address that. The downside of that is that in terms of the calculations that were done for vaccine distribution, is the numbers for the SNFs and the assisted living facilities were apportioned to CVS Walgreens and not to the county. We may not be able to reclaim those doses down the road, but again, we felt like protecting our most at-risk, most vulnerable population was important.
And I think we're doing something similar in Riverside. We're tracking where we have the number of cases by facility, by staff, and by residents. And so if it looks like it's going to be far out before we get to those through the pharmacy partnership, then we would definitely be open to looking at doing them ourselves. Resources are stretched tight, but this is our very vulnerable population. And the state has been a great partner, and I'm sure that we could figure out the allocation piece after the fact on the back end.
That's great. That's great to hear. We certainly want to be as creative and nimble as possible.
Thanks, Heather, for continuing to bring this issue up. Lisa, did you want to make a comment still?
I'm kind of piggyback on what Heather was saying, and I really hope that that Robert, you are right, because I had conversations just this morning with ombudsman coordinators from some large counties, and they're getting literally frantic phone calls from administrators of assisted living facilities that are being told March. And so not 30 days, we're looking at 90 days. And my fear is that there's going to be so much pressure from these other tiered organizations to get the vaccine out to them that we're just going to plow and skip over the long-term care residents. So I had a real specific question. CDPH issued their massive spreadsheet on January 3rd that listed all of the assisted living facilities and skilled nursing facilities that were participating in the Walgreens CVS pharmacy. So I was just focusing on the skilled nursing because we haven't really triggered the assisted living. So we've got 1,230 skilled nursing facilities. To date, 465 of those skilled nursing facilities, based on CDPH's chart from the 3rd, should have been vaccinated between December 24th and today. How accurate are we? How close to that 465 have we gotten? Because I think we're getting the cart in front of the horse when we're starting to talk about these subsequent tiers, when we don't have data to determine whether what we've proposed is working yet. But I appreciate that this is really hard. I appreciate that there were 2 major holidays between December 24th. And so I don't mean to sound so incredibly harsh. And then my camera freezes. So I'm looking really funny as I'm saying these things too. But yeah, so out of 1,230, 465 should have been done. How close are we to that 465? Thank you.
Rob, can you answer that question?
We have data from yesterday of around 200 within the pharmacy partnership program and another few hundred in Los Angeles. And I don't know how up to date those data are. So below the 1/3 mark that you're quoting, but I'm not sure where in between the 200 and 400 we are as of this afternoon.
So Rob, can you advise Lisa and everybody else on the committee, what's the best way to keep up to date with, or as up to date as the data is, with how the program is unfolding across the state?
We're sharing information as soon as we get that with our local partners, so that they can do this critical tracking as well and seeing the pace of coverage. So your local partners will have access to that information.
Okay, well, I guess I'll have to take a deep breath. This is a tough one, and I know there's so many people on the committee and listening in that are concerned about this issue, as we all are. Unfortunately, we have lots more questions, but we've already run over on this section of the agenda. So for those of you that still have questions, if you could put them in the chat, and if we have time at the end of the meeting, we can cover a couple more, and we will circle back with more answers to more questions over the next couple of days. Nadine?
Thank you so much, Bobby. And now we're going to move forward to the part of the conversation about community engagement, equity, and vaccine acceptability. And we'll be continuing this conversation. So it's been an ongoing conversation. Next slide, please. In our last meeting, you all heard a bit, or not last meeting, but the meeting before, you heard more a bit about our Vaccinate All 58 campaign. And we heard a bit from Marisela Rodriguez from the governor's office about how we are planning and beginning to launch some of our communications work. And I wanted to highlight that when we talk about we recognize, again, coming back to our key foundational principles of safety, equity, and transparency. When we think about what that means in our framework around equity, in this conversation, I want to just highlight and reflect to everyone that when we're talking about equity, there are a couple of different ways that we operationalize that. And we heard earlier Anthony ask the question about what's the remedy, right? When we're identifying issues of equity. And one part of that is, as Anthony mentioned, us tracking the data to understand how are we doing? Where are we in terms of equity? And that is what Dr. Chapman introduced at the beginning in terms of looking at potential metrics, looking at the Healthy Places Index, and hearing your feedback about other potential measures for addressing, understanding, what we can use for a vaccine equity metric. So we're very grateful to Dr. Chapman for all the work that he and his teams are doing in CDPH around developing a vaccine equity metric. And then once we have that data, once we have that information, there are a couple of different ways that we use that. One of the ways that we incorporate equity into this process is through the work of the Drafting Guidelines Committee, right? Consideration of equity in our tiering framework, and looking at the data and using that to incorporate that into our tiering framework. So this is the work that has already happened, your input into and this conversation being taken back to the Drafting Guidelines work group and being incorporated in the tiering frameworks as we are pulling them together. And then another key part of how we are operationalizing equity is with our communication framework. And that's what we're going to hear a little bit more about now, right? So making sure that we are effectively communicating to make sure that every Californian has access to information about how they get the vaccine, evidence-based information, and culturally relevant information. And as we move forward, next slide, please. Taking into that process, right? We spoke about our framework, our communications framework, which includes an acknowledgement of the complex and nuanced personal and community experiences, and an understanding that lived experiences shape willingness to accept the vaccine, a commitment to engagement by partnering with diverse communities across the state to share knowledge and information about the COVID vaccines, and action by providing everyone living in California with culturally competent fact-based messages so that they can make an informed decision to vaccinate. And, following our presentation of that framework, what we heard back from you was that you also wanted us to see that this framework informed with principles of safety, equity, and transparency. And so that has been shared back with all of our teams, and that is being incorporated as part of our efforts. Next slide, please. What we also heard from you was feedback on what some of the barriers are, and then also what are some of the motivating factors that help people make the decision to vaccinate. And so we heard lots of different factors, some logistics, some personal about payment, criteria, special conditions, trust, risk and protective factors, cultural, social, and historic factors, confidentiality, safety concerns, capacity building, general safety, cost, accessibility, eligibility, all of these things, and also clear communication about when and how to receive the vaccine. Next slide, please. And so as we, what we would like to do now is share with you all what we've heard in some of the research that we have done here within the state from our Department of Public Health. And for that, I'll turn it over to Martha, who will be able to share a little bit more about some of the data that we've received, and then hear from you all, following some of these comments, we'll hear from you all whether or not these ideas and some of the data we're hearing, whether that resonates with what you're hearing from the communities that you represent. So I'll go ahead and turn it over to Martha.
Yes, thank you. Yes, we wanted to kind of highlight a couple of key takeaways from the literature review we've been doing. We still have an ongoing literature review. We are committed to do a very robust, especially on the latest and greatest of the academic findings. But we wanted to kind of just sort of share that this resonates with the feedback that you guys had. The literature has told us that communities want access to credible information, and they want detailed information. They also want to know about the transparency of the vaccine development. They want to know what the vaccine safety standards. People are very interested in detailed information, such as ingredients. They want to get educated on the types of vaccines. They want to make that informed decision on which vaccine really would work best for them and for their families. They want to know about the phase distribution, timing, the safety, the eligibility, the costs, where can I get it? Sort of the common themes that we've been hearing. The risk and the benefits of the vaccine, any potential side effects, short-term, long-term. They really want to have that clear understanding. A really important and critical one has been cultural and social factors. They really want to know if the research and based on the vaccine trials was really under study among the communities that reflect their communities. Did doctors like them approve the vaccine? Did they have an input? The communities really want to know detailed steps on the development and process. We also know that attitudes and perceptions are divided and are changing. They also the point about efficacy, they really want to understand, the safety around the vaccine. And that has been a very strong theme that the communities are asking a lot of questions. The willingness to adopt continues to be fluctuating and has fluctuated. So it's something that we're monitoring through the various data sources and research. Next slide. We wanted also we were able to find additional insights from some of our partners from the Kaiser Family Foundation, the DuPont and PPIC organizations that they've been doing national surveys and also here in California. But some key motivators that we found that we interesting and we wanted to share is that communities want to return to normal, the safety of the vaccine and the immunity. Family has become and shown as a very powerful motivator. The messaging that is testing very well is that 95% of it is efficacy. The vaccine has an extraordinary effectiveness on protecting them from the virus. They really want to hear that type of messaging. They also want to understand and hear that the vaccines will help bring the pandemic to an end. We're hearing about the hesitation and the tiredness that communities have. They really are looking for this solution. They also the message that also is resonating quite well with them is that the vaccine will help them keep themselves, their family, and their communities' health and safety. They really want that reassurance and assurance along the way. Next slide. Specifically, we have also looked at some of the disproportional communities. We will continue to monitor other communities, but key insights among the Latino Latinx community. This is one particular group that is more motivated by the statement about taking the vaccine and knowing that that's the right thing to do, than by getting the vaccine will keep your family and friends healthy and safe. So the message or the statement that it's the right thing to do really resonated with them. They're also more motivated than the general public by the potential stop of wearing a mask. They really are looking forward to that vaccine. They want to change their social norm of what they've been practicing. Regarding the consequences for not getting a vaccine, there was a series of statements. The Latinx Americans really ranked that the potential for their family and friends to become ill was something that concerned them, and that was something that also potentially would motivate them, as opposed to a statement about damaging the economy, which ranked the highest by all respondents. But for the Latino community, it really came for that protective health reassurance within their circle of immediate circle within their family. Next slide, please. Key insights on the African American, the Black community. This is a community that within the vaccine, there's a generational divide, and it's most pronounced among Black Americans when it comes to what outcomes matters most in this pandemic. This is like Latinos, they're not monolithic. It's something that we need to monitor. But also the statements about returning to normal, the desire about that, especially among African Americans under 50. But those that were over 50, saving lives seemed to be the highest priority. So you can start to see some differences on the messaging that within the community they want. Regarding the consequences, similar to the Latino, they really ranked the potential of their family and friends to become ill. That was as opposed to the economy. So you can see some similarities between the two communities. Next slide, please. Some key insights in progress. We're still continuing to monitor research for the Black community, Indigenous community, people of color, Asian, Pacific Islander, Middle Eastern, North African. We also want to have some more insights on diverse audience segmentation, such as people with disability, LGBTQ+, people with pre-existing conditions, people experience homeless, farm workers. We're still exploring and getting additional more data. We're also going to be looking at in culture and language findings within the communities because messaging within those languages will also matter. And I think I punt it back to you. Thank you, Dr. Burke-Harris.
Thank you so much, Martha. Thank you for doing this important work. And so we want to take a moment to get your input and insights. If we'll move to the next slide, we'd love to hear your feedback. Do these insights resonate? And what communications tools do you all think would be beneficial? So we'd like to go one question at a time. If we want to jump in first with whether or not these insights are resonating, or and if so, how?
Great. Okay, we've already got lots of people who want to talk. So let's start with Dr. Tan, and then we'll go to Melissa Stafford Jones, and then we'll go to Ronnie Kelly, and then to Deborah. Jay.
Thanks, Bobby. I would say that this very much resonates with my experience, and I want to just thank you for doing that literature search. I learned quite a bit as well, so thank you very much. I think one thing that I would also emphasize is, so we talked a lot about what the message is. I also want to raise that it's important in terms of who the messenger is, right? And so I think that we've talked about this in other conversations, but the importance of having people of color, healthcare providers, promotores, community health workers that identify with the populations in dialogue is very important. And that's also backed up in the literature as well. I'll just say that one of my patients, I had a conversation with her about vaccine hesitancy, and she was very concerned about how the vaccine was developed for white folks and not for Black folks. And I shared with her that I, with a group of people, meet with Dr. Burke Harris every other week. And Dr. Burke Harris has really emphasized the importance of equity. And she was like, okay, well, let's talk more about this. And that's really, I think, I mean, it's, the Surgeon General is, holds a lot of weight. That's, you're a great messenger, but also because my patient felt like you're part of the community that she belongs to. And so that's this credibility that I think is really important, cannot be understated.
Thanks, Dr. Todd. Melissa, and don't
My
forget.
comment on the second question, so it sounds like I should hold.
Okay, hold on one second. Ronnie?
Hi, Ronnie Kelly, County Behavioral Health Directors Association. I would say that all of these points are really resonating in our communities. In the county that I'm in San Bernardino County, we have done listening sessions to our communities of color. And it's very difficult not to jump in when someone says something like, well, it's not been tried on my people, to refute it and come up with an answer when what they want is to be heard. So I think that is a great way to really address equity and do it in a really transparent way. And then also the mental health community has a long history, like our other disabled communities, of really being mistreated by the medical system, writ large, especially when you think about things like psychosurgery that's been done to them. And so what we found and what we've heard from our clients, the people who have serious mental illness that we are serving in the state, is that they trust their providers. So they trust their therapists, they trust their psychiatrists because they don't see them as being part of the bigger medical system. And so I think if we listen to them, like what we're listening with the research, that will really help advance the ability for these folks to make that decision and get vaccinated.
Thanks, Ronnie. Deborah.
I just want to make one point about the issue with our healthcare providers that are already in phase 1 choosing not to take the virus, and how that translates to the general population increasing their fear. I think that's a barrier, and I also feel like we've got to figure out a way to message over that, given the pathways and also given the information that you provided, which completely resonates with our communities as well. You just need to find a well-trusted mentor, a well-trusted person that can deliver the message, I'm getting the vaccine, you should get it too. Because I do know that chatter is in the community. A lot of people know that healthcare systems are not getting really high rates of uptake.
Thanks, Deborah. Carol, do you want to comment on the question about, do the insights that were presented resonate with you and your constituents?
Sure. I'm Carol Green with California State PTA. I was going to say something similar to what Deborah just said about the people hearing about the medical community not all jumping on and quickly taking the vaccines. I think the points resonate for the most part. I just think that we need to also have a strategy for combating the misinformation that's out there. I was just on a call today and someone said to me, well, I heard that it sterilizes people. And this is the fourth person I heard that from. And I said, well, so I would really like for us to have some ways to combat this information. And the person who told this other person was a teacher at a school that was having a conversation with the class, that we just don't know very much about it. So I just really think we need to get some tools to combat the misinformation. And then they said, well, where did it come from? And I said, well, where did all these conspiracy theory things come from? But we still have to have some tools for that. So I think that the messages are great. And I think we just need to also have some tools for the misinformation that's out there.
Thank you. Thank you, Carol. And because this is a public meeting, I just want to be on the record and being very clear that is false. It is a myth. The vaccine does not sterilize people. And the second thing I actually wanted to speak to was something from the slide around the not wearing masks. And I just want to be clear that at this point, even when people are vaccinated, we still need to wear masks. And so just wanted to get those points clarified.
Thank you, Nadine. I think Carol's comment was a perfect segue to the second question, which Melissa Stafford-Jones comment on, like Crystal also. So let's get a little more feedback in terms of what additional information would be helpful to each of you. So Melissa, why don't you go first and then Crystal?
Thanks, Bobby. Melissa Stafford-Jones with the First Five Association of California. I wanted to just share a few reflections from our experience, and I know many of our partners with the census work, and I know we talked about the possibility for census. I do think the prior discussion around the importance of very
Would everyone not speaking please mute their line, please?
We were all unaware of what was happening right outside this room. Because
Melissa, you'll have to unmute.
Oh, there we go. The lessons learned from the census, I want to just reiterate what was stated before around having targeted messages that really resonate with specific groups in localities, as well as from trusted messengers, we know is critical. But I just want to share a few other lessons learned from our census work and from that of our partners around that. One is that the use of short videos, 15 to 30-second videos from trusted messengers that can be used in a variety of formats, whether it's social media or right in the moment on a phone talking to someone, we really found to be a very useful and powerful tool, and that can be really from trusted messengers, very customized, really short. And so hoping that that's part of the toolkit and the campaign thinking that people are thinking about. And also I noted that there was use of PSAs. And I just want to say, we also found that particularly in areas with limited internet access or limited social media access, PSAs are very important. So just want to express appreciation that that's there, and that keeping that as sort of a vital part of the campaign we found in the census work is really critical. Thank you.
Thank you, Melissa. Really helpful reminders there. Crystal.
Hi there, Crystal Crawford, Western Center on Law and Poverty. My comment is really related to the first question, but relates to the second one too. The framing that worked for folks around protecting their family and friends, to me, connects to this notion that we need to lift up for folks that this is the right, it's a good choice for them to make to take the vaccine, as opposed to us telling them that they must take the vaccine, and if they don't, they're not responsible. It's like because of the vaccine hesitancy and mistrust of communities, we have it, the framing and that answer that folks gave around my goal and my motivation is to protect my family and friends really lends itself to this notion of this is it's your choice, it's an empowering choice, but we're not trying to take that choice from you. It's your decision, kind of like the tools in your toolkit approach, right, that we use in sexual health and prevention work. And I think that's just a really important nuance to what you heard from folks in your survey and questioning.
Thank you, Crystal. Carolyn?
Hi, can you hear me? Sorry.
Yeah.
Hello. Hi, my name is Carolyn Tamaris. I'm from the Indian Health Service here in the California area office. I wanted to address the type of communication mode that should be taken into account when communicating to Native American communities. A lot of our communities are located in rural areas that may not have Wi-Fi, so they may not be able to get email or certain internet capabilities where they can access this information. So our tribal and urban healthcare programs could really use toolkits that they can customize to their needs. So if you can have those flyers that they can, add pictures to suit what their community can use, that would be most beneficial for our sites.
Thank you, Carolyn. Really good suggestion. Moises, why don't we take a comment from you and then we have another short presentation on this topic.
Yeah, thank you. This is Moises Baron with the California Alliance for Child and Family Services. I was thinking, people were talking about the messenger, somebody that would be credible, but I think that in some communities, we need to identify what that means. And that frequently somebody that is emulated or that may have star power, for example, in the Latino community, if you were to take a soccer star, being able to really show that they're doing this and be able to communicate the reasons why they're doing it in a brief message could have a lot of power where you don't have to go into a lot of details. Something similar in San Diego, the Department of Behavioral Health could develop a whole program using the concept of telenovelas, which as a means to be able to communicate these messages in a way that feels congruent to the community without having, again, to address a lot of the specifics, but rather doing in a manner that resonates and also with people that resonate with the community.
Thank you for that. Okay, I think we're ready to hear from Maricela Rodriguez from the Governor's Office about the continuation of this discussion on community engagement. Maricela?
Hi, are the slides going to go up? Great.
Here they come.
And I just want to give Martha a shout out because I feel like that there's been comments on census now and then before, and she's helped spearhead the communications work over at the census office. And she's now stepping in to help with the ongoing work that we do on the communications front as it relates to the public education campaign. So we are intentional about how we leverage our knowledge, our learnings, our infrastructure to give us a leg up in developing this campaign. So appreciation to her and other folks in the census office who have been working with us to help and provide insights to how we move forward. So just quick reminder that, when I presented last, we launched with the campaign. We launched with just a few tools that we put into the toolkit. We had some social media messages, graphics, fact sheet that was translated, and we continue to translate in additional languages. And as they get translated, they're plugged into our toolkit. There is a special page for partners that just wanted to call it out because that particular page on our COVID website also has the logos and the brand guidelines. As you may recall, the logos also were created logos for each county so they could quickly be lifted and adopted for those who choose to do so, trying to make it as easy as possible for folks to jumpstart their own campaigns and communications. So next slide. Wanted to mention that, as we move into the next phase, we want to recognize that we have sort of a multi-pronged approach. We have two major audiences. We have all Californians, right? Everyone knows the vaccine is here. We need to continue to relay those basic information that we've talked about before. But we also have we have a phased approach. So we also want to be targeted and intentional about reaching those populations. So we have two tracks that are running on parallel tracks. And just wanting to highlight that's the approach that we're taking. And so in the previous presentation that we did, some of the information that was collected was, those key messages that we need to continue to relay to everybody to build confidence in the vaccine, target, tackle some of the mis and disinformation that was raised earlier in the conversation around safety, effectiveness. It's at no cost, your information is protected, and the intention to leverage trusted messengers as we move forward. So next slide. For all audiences, this is just to begin with, this campaign will continue to develop additional assets, but moving quickly, two basic assets that we want to have is one is a general public service announcement that covers the basics, just the facts, those key messages that we've talked about before. And then based on the conversation we had with this committee previously, having something that can also be very visual for folks that highlights those key messages in simple form, and gives some kind of pictures, icons that help people walk through some of this information. And so that's what you're going to be seeing next. And from that, we want to build additional content. So next slide. And so as we look at 1B populations, you've heard, this is going to be, a very big challenge. And so we want to create content that is tailored to particular audiences. As you heard Martha run through, there's particular messages that are going to resonate more with specific populations. We want to ensure that we're also leveraging trusted messengers to those particular populations. So thinking about how we tailor content to reach specific populations in a way that's going to resonate with them. We also want to continue to work with ethnic and multicultural media. We're building a campaign that needs to be surgical and nimble. And so we have to leverage assets that allow us to do so. And so that's going to include things like regional media briefings that reach both press and folks across the state. We want to generate content and articles that help us walk through information that people need to understand in more detail. We want to do live reads across different ethnic media outlets. Those are done through DJs that are also considered trusted messengers. It also allows us to move faster, and it allows us to be nimble as we need to change information or update information. We also have partnerships with Spanish media that include folks like Radio Bilingüe, where we have 1 hour long radio programs, and we bring in trusted messengers and experts to walk people through some of these complex issues. So we want to continue to leverage those kinds of tactics. So we're looking at both paid and organic media tactics. Wanted to mention that as part of our own ongoing efforts, and also just give credit to some of the folks that sit on this committee. We mentioned that we wanted to put out testimonials of healthcare workers who are receiving their vaccinations, because we recognize that there is some hesitancy even within that population, and want to make sure that there's a positive narrative out there, because there are folks that are taking their vaccine, understand the importance of how it can protect their family, protect their community, move us forward in ending this pandemic. So there have been a couple of organizations that have helped us with collecting those testimonials, putting them out organically, as well as us being able to collect them, create specific content, and put it out through social and digital paid. So and that includes folks like UC Davis Medical, SEIU, Kaiser is a partner that's going to be working with us moving forward, CMA, the California Hospital Association, among others. So really appreciate the work that folks are doing to really help us build a positive narrative around vaccine take up. So next slide. Also wanted to mention also, the importance of reaching folks where they are and through trusted messengers is going to require working with CBOs. We have been engaging folks along the way, but in a more formal manner, we are working with LWDA and CDSS to build a very coordinated cohort of CBOs in a similar way that we thought about the work of the census. Having both the air game and the ground game is very important, and to have those two things coordinated is even more important. So we do have coordination across all of these different departments and agencies. So right now we have a state investment that will allow us to invest approximately $30 million and fund approximately 150 CBOs. And we are working closely with philanthropy to also coordinate efforts around their investments as well. And so 30 million is just the state investment. Philanthropy also has their own investment, and we're in conversations to have a coordinated effort moving forward. Next slide. Just a quick snapshot of our timeline. To try and move in an expedited manner, we both DSS and LWD, as part of the coordinated effort, have reached out to specific organizations that have a strong track record in reaching the specific populations we're aiming to reach. That process should conclude in January, looking to onboard quickly in February. so that, you know, the insights that you are sharing about what tools and information and messages are important will help inform as we create toolkits for those CBOs as they come on board, so they can be ready as soon as we have them in this onboarding process. We are also working with census staff to help us understand the things. And as just a reminder, I helped oversee the census campaign, which helps also facilitate sort of those conversations with the census team, what worked as well as what didn't work so well. And so leveraging those learnings, especially outreach, is much different during a pandemic. We are going to be providing PPE to partners who are going to be doing outreach so that they can do it in a safe manner. We are going to leverage the learnings about how we do this in a safe manner during a pandemic and follow public health guidance. So both all of these strategies are things that we have in mind, and leveraging Census Insights, as well as the partners that are going to be coming on board who know how to reach community where they are in a manner that is going to be safe and effective. The partners that are coming on board are part of our COVID-19 response overall, but vaccination is part of their efforts. And so that's going to be a key priority as they come on board. If there are organizations that you would like to raise to our attention for consideration, please let us know. As we continue to move forward, we would love to have those insights. I think that might be it. If we go to the next slide, I think I might be done. I'm probably sure that I missed a lot of things to share, but happy to stop talking at this point.
Thank you so much, Maricela. And I think that we can kind of lower the slides for a second so that we can facilitate seeing each other when we're having this conversation. So first of all, I want to thank you, Maricela, for your tireless work, because I know that you are another person who has been working around the clock, really with very little rest, and very grateful for your leadership in moving this work forward. I wanted to also share, in addition, that yes, we have been working very hard, and Maricela and her team has been working very hard to move this process forward as quickly as possible, and really recognize that part of the process of, reaching out to having the governor's office and having our teams reach out to partners who have been extremely effective messengers in the past to move forward in this expedited process, so that we can get partners on board and get those contracts flowing by February, has been really critical. But we also recognize that in doing that process, right, that there may be other community-based organizations that are really doing excellent work. And I see in the chat, there's a question: how can CBOs and smaller grassroots organizations apply for some of this funding to be doing the community outreach? And the governor's office, in coordination with CDPH, is working closely with philanthropic partners on a pooled fund, as Maricela mentioned, of roughly $27.5 million to support COVID response, which includes funding CBOs to promote public awareness on vaccines, and particularly for vulnerable communities. And this work is happening in partnership with the Public Health Institute. So if the members of the committee have recommendations for community-based organizations who you believe are well-positioned to educate communities, we invite community members to share those ideas with us by the process of emailing Bobby or emailing us through this committee process. And we will pass those names on to the Public Health Institute for consideration. And for that, I want to open it up if there's any additional questions.
Thank you, Nadine, and thank you for adding that last comment, because I know a lot of people were interested in knowing how they could participate in this. So let's start with Andy, and then we'll go to Deep, and then we'll go to Lisa.
Thank you. Thanks. It's Andy Imparato with Disability Rights California. in the communications around the 1B phase implementation, can you clarify, I think I must have misheard at the beginning, but the different tiers within 1B, is tier 1 going to go before tier 2, or are all of the tiers in 1B going to happen at the same time?
That's a great question, Andy. Rob, would you just quickly go over the tiering process in phase 1B, because it's a little different than the process in 1A.
So tier one, those who are in tier 1 get access before those in tier 2 within 1B. Tier 1 goes before tier 2, but within the tiers, there's equal access.
So if you're in tier 1, you have equal access to other people in tier 1, but if you're in tier 2, you have to wait until tier 1 is done. Got it.
Yes.
Thank you.
Thanks, Andy, for that question. Deep.
There was also a question of, as we move to tier 1B, will folks in tier 1A still have access to the vaccine? And the answer is yes.
Good. Okay, Deep, it's your turn.
Yeah, thank you, Bobby. I just wanted to go back to Kim and Eric's comment very quickly about people.
Introduce yourself so everyone knows who you are.
Oh, I'm sorry. I'm Dean Chalius with the California Association for Health Services at Home. We're the home health and hospice and home care aid folks. Sorry, Bobby. I just wanted to go back to Eric and Kim's presentation. And there was a lot of discussion about long-term care facilities and SNFs and others. And I want to make sure that we remember that those that are being treated in home health would otherwise be in those facilities. So they are equally vulnerable. And of course, home health agencies have nurses, and per Dr. Brooks, get us the vaccine and we'll get the vaccinations done. And so I just want to make sure that we remember that. And also, I think, Kim, you made a comment about some folks at the county level or the local level scouring the internet for a list of home health agencies and home care aid agencies and the like, and we can get that for you very quickly. So please connect with us. Thank you, Bobby.
Thank you, Dean. Now we'll hear from Deep Singh.
Sure. Thank you so much. This is Deep Singh from the Jakarta movement. And I just wanted to thank you, Marisela, for just the sort of thoughtful presentation and finding different ways to include community and supplement that with sort of the ongoing sort of engagement. Specifically your office, I just want to highlight in terms of just how receptive and how immediate they've been in terms of taking feedback from us, from other community partners. I really appreciated the effort specifically saying what were the best practices with the census and really kind of tying similarities in terms of the messaging, especially for the most hard to reach communities. And even to Dr. Tan's point earlier about really empowering and trusted messengers, I was wondering if you could just kind of highlight that component, especially that census learning. I know you highlighted Martha and others from the census team that were part of that. But if you could kind of just underscore some of those points, because I think it's really important for this advisory committee to hear, for the general public to hear. But I think there were some key learning lessons, and the success of the census really informs an evidence-based, a data-informed, and sort of best practices model that we're all trying to do here at the state.
Yeah, appreciate that comment, Deep, and your work on census and your willingness to always provide feedback on our questions. So, Martha, I don't know if you want to jump in or if you want me to take that question on the insights on census and the trusted messengers.
Yeah. Hey, good evening, Deep. I think one of the best lessons learned and best practice that worked well within this census campaign was that we use a multi-layer approach. We had on the ground trusted, credible individuals and organizations that were communicating with the communities. And then we complemented that with the air game. And we use various different partners from general market, ethnic media was really something that we focused a lot. We also use the trusted messengers within that media practice. We use key hosts or or TV personalities. We also use social media influencers that really resonated with the communities. So we had a multi-tier level approach that really was able to target and reach. Census was the hardest to count communities that traditionally or historically don't participate in the census. So that is a lesson that has been learned, and it's something within public health has also been emulated with other programs, but also in the best practice.
Yeah, and I would add that, I think the why the CBOs are so important is because, these are organizations that deal with and communicate and engage the communities that we're aiming to reach on a daily basis. And so having them talk about this issue is going to be critical in this effort. As much as the influencers are and like trusted anchors and DJs and things like that, we know that the stakeholders that reach these communities are trusted messengers, and we want to engage them intentionally moving forward. And I actually, you reminded me of something that's not necessarily totally related, but just because you mentioned like best practices, with the census, we created a hard to count index, and we want to, since there was a conversation earlier about how are we going to inform our efforts? The hard to count index allowed us to really be targeted in our efforts to ensure that we were reaching the communities that were to reach to get counted. In a similar fashion, we want to leverage data at COVID positivity rates, the Healthy Places Index, using a very data-driven approach to help us ensure that our outreach targets, both in the folks that we're trying to reach and where we're trying to reach them, is also informed by that data, and that we're being intentional of working with organizations that reach those communities, and duly noted it, and have in our plans to work with organizations that work with people with disabilities in all those hard to reach communities. So thank you for allowing me to mention that note that I forgot in my presentation.
Thanks, Maricela. Lisa Hershey.
Hi, Lisa Hershey with Housing California. I really want to just echo what Deep just shared. I was on the Complete Count Committee, worked very closely on all that for a significant amount of time, and so grateful from a public health practice perspective that we are building on the infrastructure, we're building on the lessons learned, and I'm super grateful to Maricela and Martha and Department of Public Health as well, that you are using that and rolling out a very clear and consistent campaign. And I was going to offer, from my perspective at Housing California, we helped bring Homebase to the census because there was no statewide entity that was really connecting with the continuous care, and would like to emulate that or build on that, Maricela. So, would love to help with that. I know Martha also has that relationship. And then also, we work with the affordable housing developers who have huge multifamily housing developments with a lot of people that are disproportionately impacted by these inequities, and a lot of seniors in different groups. And our developers are very, very interested in helping with the outreach and engagement, as they did with census, to make sure that both their staff that are essential workers that also tend to have low income and are disproportionately impacted are vaccinated, but also can help engage their communities as trusted messengers and do it on kind of a population-based scale. So I just wanted to offer those as well. So thank you so much. Excited to contribute and be helpful.
Thank you, Lisa. Orville, did you have a question that you wanted to, or a comment that you wanted to make?
Yeah, thanks, Bobby. This is Orville Thomas from the California Immigrant Policy Center. And this is for Maricela. Just as we think through this, hoping that obviously the involvement with the One California program and service providers from CDSS is there. We've obviously learned that there are a lot of asks to be made, especially with the disaster relief assistance that was rolled out, and how it kind of overwhelms some organizations at certain points. So maybe working within the parameters of already established organizations that have these trusted relationships with immigrant community members is going to be the best way forward. Something I'm sure you already know and have started to have these conversations on.
Great, thank you. And Maria Lemos, are you still on, and do you have a comment you'd like to make here?
I am on.
Good. Where's your camera? We can't see you.
It's here. I'm here. I think that it's really important to. I love what Martha and Maricela in terms of the going deep into the community. I'd like to see that expanded a little bit more. I think that would be really important. And the diversity of our communities, not just the Latino. I don't know if they spoke to any of the indigenous groups, for instance, how deep they went into that. But the messaging, we have a lot of agencies that do messaging already, and I hope that we can engage us at the CBO level. I do have one question about Public Health Institute. Is the criteria for the review of who participates in these grants, so is that going to be established by PHI or by DPHS or by the funders or who?
Let me circle back on the PHI comment. I want to make sure I gave you the right information.
Okay.
And on the previous comment, we are looking at how to reach all diverse communities. So we also work with like Radio Indígena and Radio Mixteco and are looking at, we have a pretty extensive list of ethnic media that reaches API communities and broader than that. So we do have a pretty extensive and robust list of ethnic and multicultural partners.
Great. Can I just say something about PHI? I think that I understand the idea of putting money in one pot and one agency to coordinate it. And the reason I asked the question about the criteria and who establishes that is, the devil's in the details, and sometimes the establishment of that criteria can leave out or not include community-based organizations. For instance, in the contact tracing requirements, and for those, there is one requirement that they have to have a high school degree. And I've been talking with them about changing it because that leaves out a lot of the promotoras and the possibility of them getting involved. And so there's no one who assumes responsibility for that because they put it back on health puts it back on them. And I think that if there's somebody who's overseeing the little details like that, that really can, for us from community-based organizations, can fully participate, I think that would be really an important oversight.
Great feedback, Maria. Thank you. Marcela or Nadine, could you, as we wrap up, talk a little bit, or maybe Brian from the endowment, who the philanthropic partners are for this endeavor?
I can say that I don't have that information directly in front of me right now. I know that it's a pooled fund, so there are several philanthropic partners who are involved, and the Governor's Office of Social Innovation has been helping with this effort, and I can certainly commit to coming back to this group at the next meeting with more information.
Great. I think people would be very interested in that for sure.
Brian, did you have something to add?
Hi, folks. Sorry, it's Brian Mingmore. I was on mute from the California Endowment. I put into the chat that I'm happy to help provide information on the Public Health Institute and their role and the criteria and whatnot, and provide it to Bobby and staff for distribution.
Great. Thank you, Brian. So one last question that's come up over and over again in our chat and in the public comment. And before we end, maybe we could reiterate this. There's many questions about when will phase 1B begin? And I know we've talked about it, but Rob, I wonder if you could just clearly restate sort of the timeline for 1B.
So right now, we're in 1A through, and there's access to eligible healthcare workers and residents in all tiers of 1A to the extent that supplies and clinics can reach them. And very soon, as the supply increases over the next weeks, we would be expecting a formal announcement of when 1B is in effect.
Okay, thank you, Rob. Okay, Dean, I think we're ready to start wrapping up as we're very close to 6 o'clock.
Wonderful. Well, thank you so much, Bobby. And I want to close out by sharing a little bit about some of the key themes that we heard today. Really thinking about the importance of trusted messengers and really sharing with you our plans for engaging with trusted messengers, engaging with our community-based organizations, both directly through our effort that is funded by the state of California, and then also by partnering with our philanthropic partners as well. And we also heard from you today support for the Healthy Places Index and for the notion of using a social vulnerability index, and also a request for further consideration for tools that can also better serve individuals with disabilities. And we started off the meeting hearing about from Dr. Pan about the balance between really focusing on the operationalization of getting those vaccines out and trying to get as many doses out as possible, while ensuring also that we are adhering to the concepts of priority, right? That we are making sure that we're getting that vaccine to the communities that have been prioritized, but then also recognizing that there may need to be some flexibility as we're going into that process. And so I really want to just thank all of you for all of your time, all of your excellent suggestions in making this Community Vaccine Advisory Committee just a really strong, useful, and productive process where we can hear from you. How do we constantly improve? How do we constantly make this process better? We know that everyone in government is working tirelessly right now on so many different levels in fighting this pandemic, in addressing the outbreaks and the surge and contact tracing, and providing PPE and providing resources to all of our providers and our essential workers and folks on the ground, and at the same time launching this vaccination effort, which requires a tremendous amount of logistics and operationalization. And from that standpoint, we're incredibly grateful to hear from you what we can be doing better, how we can be doing it better, hearing your suggestions of how some of these things are landing on the ground, recognizing and hearing from you where things can be going better and how we can be more thoughtful in approaching this process. So we're incredibly grateful for you all showing up meeting after meeting after meeting. They're long meetings, and but with this strong sense of commitment to our communities. And with that in mind, our next meetings are January 20th from 3 to 6 p.m., then February 3rd from 3 to 6 p.m., and the next after that being February 17th from 3 to 6. As has been the case, you all will receive the agenda before the next meeting. And I want to invite members of the public. Thank you so much for tuning in. Thank you for sharing your public comments. We read these public comments, we incorporate them into our discussions and our considerations. And anyone who wants to make a public comment can do so by emailing COVID-19 vaccine outreach at cdph.ca.gov. And with that, we are at 5:59. I want to thank everyone for your time and your participation. And with that, we can adjourn.
Good night and Happy New Year.
All right, thank you.
All right, thanks everybody.
All right, Happy New Year.
Happy New Year.
Thank you.
Well, soon. Thanks for joining.
Thank you.
Thank you.
Thank you.
Take care.
We're sorry. Your conference is ending now. Please hang up.
Hey, Aaron.
Hey,
Fastest way to copy the chat is to scroll all the way up.
oh yeah, there should be a three
I'm-
dots in the bottom right of the chat, and then you can save chat.
Oh, God. Oh, save chat. Okay, and I wonder where, there's it show.
Should have a show and folder button.
Yeah, I see that there. I wonder if I open it, if I can turn it into a, so I wonder if I can turn it into a Word doc.
Sure. So I think if you just open up the meeting save chat notepad and then Control A to highlight it all.
Oh,
And you can,
this is going to work. Control A. Uh-huh. And then?
You can do Control C.
Oh, to copy it.
Uh-huh.
And then to put it in a Word.
Yeah, and then just open a Word doc and then Control V.
Yeah, that I know. I want to see how it'll come out because usually I copy it because I clean it up and send it out to everybody.
Mm-hmm. Gotcha.
Oh, yeah, they're not great. Okay, so that's great.
Perfect.
Oh, I got to shut off the live stream. I'll do that. How many people were watching?
Somewhere between 600 and 700.
They're getting.
Yeah, which is
Yeah.
just the concurrent viewers. So there's probably a lot more jumping